posting it on the EIIC website, and you're welcome to share the content. So I just wanted to be clear that your talking on this call is consent to have your voice recorded, and I really appreciate the involvement and engagement, and I'm really excited today to continue this community of practice. So just to remind those individuals on the call, a community of practice is a group of people who share a concern or passion for something that they do, and we learn how to do it better by interacting with each other and learning from each other and with each other. So for webinar 1, for the community practice, we had the exciting stories from Illinois, from Evelyn Lyons, from a program that's really been around for 30 plus years, working towards pediatric readiness, and then a more grassroots program from the Massachusetts group related to Pediatric Champions. So today we're going to hear again from one of the sort of initial work efforts in pediatric readiness from the LA group, but we're actually going to start this time with a talk from a group out in Austin led by Kate Remick, who sort of is I guess, a descendant of the LA group. So we'll hear a little bit about how she took what she learned there from Marianne and from Nancy, who we'll hear about in the second part. But Sujit, Iyer, and Kate Remick will be covering the first part. So Kate is an assistant professor at Dell Medical School, and one of the leads on EIC is the prior chair of the AAP National Pediatric Readiness Project, SIG, and also has many titles within the EMS divisions. And then Sujit is leader of the fellowship and many other aspects of the great work that the Austin group has done in collaboration with CETN. So thanks to all 4 speakers. If there's any questions from anyone, please list them in the chat box, and or we'll have a audio discussion in the second half. So our hope for this call is to achieve those same objectives from the prior call, where we learn from and with each other how to maximize pediatric readiness across the United States. So thank you, Sujit and Kate, and I'll pass things to you guys.
Awesome. Thanks, Mark. I think this is one of those situations where all good things start in LA County. So thanks to Marianne and Nancy for their long time leadership in improving pediatric emergency care. But what I was going to speak about briefly today is really what we started on the local level about 5 years ago, back in 2013, 2014, in the Central Texas area. And this was an effort really focusing on how to be kind of a regional PEC, or to provide community outreach for community hospitals and sites that are in your area. And then some of the work that Sujit has since really taken over and taken to the next level to lead this. And so he's done some amazing things with this whole network, and I'm excited for him to share that. But I don't know why some of these slides aren't showing up quite right, but that's okay, it doesn't matter. So our goals were to work within the Central Texas region, and it's called the CETN Network, which is actually part of the Ascension Healthcare Network. Ascension is the largest not-for-profit healthcare system in the United States. And our goal was to work regionally with the 10 sites that are in the Central Texas area to increase awareness around the 2009 guidelines, because at the time, the 2018 guidelines didn't exist. And we wanted to do so by essentially establishing pediatric emergency care coordinators in each of the sites within the network, and to help them to improve their pediatric readiness, because we really felt that as a network that has a children's hospital within it, we should really be on the same page in terms of assuring high quality care for children who present to any of the sites. There are about 5 medical centers that are within the Austin-Travis County area, so they're much more metropolitan, but there are also 3 rural sites. There's also some community sites that fall within the CETN network, and lots of outpatient areas, but we wanted to make sure that if a child presented to one of the rural sites, that they too were going to get a high level of care. And so our goal was to go and identify pediatric emergency care coordinators, teach them about quality improvement efforts, and then ultimately to improve their overall pediatric readiness scores, so that we could get everyone up to the same level. And we really felt that doing quality improvement efforts was a way to improve that readiness, because when we did our initial assessment of facility verification in California, we saw that having a quality improvement process similar to having a pediatric emergency care coordinator was significantly associated with higher pediatric readiness scores to the tune of about 25 points difference. And so we knew that was going to be an important factor. And it makes sense because if you're monitoring the care that's being delivered, then you can actually identify gaps and make improvements. So we had a 2-year grant. It was, at the time, we weren't actually with Dell Med School. We were actually with the UT Southwestern program out of Dallas. We were a sub-site. But we got our initial 2-year grant as part of a patient safety collaborative grant. And what we started with was just doing a baseline assessment based on the 2013 assessment of where are the gaps. But rather than doing these remotely or virtually, we actually went on site to each one of the medical centers or emergency departments within the network and did an on-site evaluation to see where those gaps were. We also identified a nurse champion at every single site, and we brought them in for an initial workshop. And during that workshop, we assessed their baseline quality improvement knowledge and what that looked like. And the interesting thing, I think, is a lot of people feel like they're doing quality improvement efforts, but in fact, they're really just doing a single chart review or looking at one particular case, but they're not actually monitoring performance metrics. So we learned a lot by doing this workshop and really talking through what kind of quality improvement work was being done. We got to know the sites really well because we actually visited the emergency departments, we met the staff, we saw how children were being triaged through their system, what kind of resources they had, and it was really eye-opening to be able to do that. The other structure to the project is we set up quarterly regional meetings. Many of these, or most of these, were in person, although occasionally someone would join virtually. But it was a chance to really work together in a collaborative environment, just like this community of practice, where we could learn from each other. We provided ongoing coaching around the individual projects. Each site was able to choose their own projects that they wanted to work on based on the gaps they identified in the 2013 assessment. And then we all worked together as kind of a regional network to develop resources that would really help to improve the work that was being done. So our goals and outcomes of this project were, of course, to identify a PEDS emergency care coordinator. We wanted to improve readiness. We wanted to create ongoing QA efforts, and we really wanted to improve quality improvement knowledge just within the system in general. Our mean score was not surprising, and when we talk about the 2013 national assessment, we know that that was all done virtually, and that was probably a best case scenario. But when we went on site, our mean network score was 64.7. So there were clearly gaps that we needed to improve upon. Some of the things that we noticed were just basic issues of weighing children in kilos. The scales weren't locking. Some of the sites ended up purchasing new scales. We developed family information sheets so that families could understand why it was so important to weigh those children in kilos. We started creating vital sign badge cards to help with the triage of pediatric patients to identify when patients had abnormal vital signs and needed to be seen more quickly. And the other thing that was particularly eye-opening as we went to these sites is that many of them didn't know where their pediatric code bags were or have any kind of pediatric code card or crash card. And so we actually went through the network and really pushed to purchase pediatric crash cards for every single site within our system because many of them hadn't even opened their pediatric code bags if they had them in years. They didn't know how much or what kind of information or equipment was there. They didn't know if some of the stuff was expired. So that was, I think, one of the most helpful things that we ended up doing during this process. We also really just kind of established some baseline processes for how to do quality improvement work. We worked with the network to identify individuals to help with pulling charts based on specific criteria. We were also working to implement an asthma management protocol that Sujit had actually led within the Children's Hospital, but we were trying to implement that more broadly with the entire healthcare network for pediatric asthma management. We started creating some nurse pediatric competency evaluations so that we could really go through pediatric triage and assessments. We developed processes for assessments and reassessments throughout the ED stay. And we also worked on developing a local formulary for pediatric drug dosing. After the course of this whole collaborative with the quarterly meetings, the QI workshop, the coaching and whatnot, We did meet what we were hoping to, which is that we at least got their pediatric readiness scores up to 91.1, and that was with on-site visits. There are about 3 sites that had pediatric readiness scores that were below 90, and the great majority of those cases, it was because they didn't have a pediatric champion. And one of our biggest challenges was that we had over a 50% turnover rate among our pediatric emergency care coordinators within a 1-year period. So over that 2-year period, it was almost like starting completely over and having to bring them on again around what pediatric readiness is, why it's important, and what is quality improvement work. Because many of the pediatric champions were from small rural hospitals where they maybe had 4 beds in their ED altogether, some of these champions were also the trauma manager, the STEMI manager, the stroke manager, everything else. And so trying to get them engaged in this process was always about trying to reprioritize their efforts and sometimes steer them away from other things, which was an ongoing challenge. We did, though, have a great achievements relative to the QI implementation work. And after we finished this project, what we ended up doing was to develop some network-wide pediatric education, the first of which was focused on child maltreatment efforts and how to kind of standardize our approach and increase awareness around that. Some of the cost of this project, so the project was actually funded by about a $60,000 grant. It wasn't, a very big grant, but it was enough to really allow us to travel to these different sites and also to purchase some equipment and supplies and develop some of these resources. It also helped that we were able to bring on our network leadership. So Seton, as I mentioned, is part of the Ascension Healthcare Network. So really bringing in the CMOs, the chief nursing officers and the like to the work that we were doing, increasing awareness around it, and also being able to even market locally around the work that was being done. We continued with some quarterly meetings thereafter, and part of the work that was being done on the nursing side was to allow them to use these efforts as part of their clinical ladder projects, which became immensely helpful for them. So at that point, I would say, our goal was that, we continue to expand across the entire network, continue to improve pediatric readiness through efforts directed at specific patient populations. We knew we still had some gaps, particularly among physician techs, and that was something we still needed to grow. So that was work that we were beginning to do. We are also beginning to look at telemedicine opportunities and how to improve pediatric readiness in rural areas and increase resources so that we can maybe prevent unnecessary transfers. We continue to work with the EMR to see how we could develop better informatics for pulling charts and also for ensuring safety, especially when it came to weight and kilos. And our ultimate goal is that down the road, could we eventually develop a registry within this network to begin to follow and evaluate care relative to specific pediatric patient populations and outcomes, and then also the cost associated with that. So I think at this point, I'll turn it over to Sujit, and I don't know if you want us to answer questions throughout or how you want us to do that, Mark.
I'm going to make the executive decision to answer some questions as they're coming up, if that's okay. And I might have to hurry things up a little bit later on. So the first question coming in order was from Marianne. Given the shared roles, what about a checklist of duties for pediatric emergency care coordinators?
Yeah, and so within each of the sites, they had their own PECs. So for us, we certainly had a checklist of how we were trying to work with each of the PECs in each of the smaller sites. The role that every single PEC played at their individual site was a little bit different just because they had many different roles that they were undergoing. And our hope was just to really start doing local QI efforts as opposed to creating a checklist, but that would have been really helpful. And I think, the checklist, obviously, that's part of the guidelines is a great starting point for that. It's just trying to say what are your roles and responsibilities and how can we formalize this role, which I think is part of where Sujit comes in.
Excellent. So we'll hear more on that from Sujit. There was a question from Teresa. Did any of the PECs cover more than one site? For instance, if there was a small number of patients, could they have multiple roles across different hospitals? And I know this is something we've struggled with in our institution, particularly for the very low volume.
So they certainly could have, but in our case, they didn't. We were able to identify someone from each of those sites. And while we talk about this a lot and how you can potentially share a PEC across different sites, I think it's really helpful to make sure that the person who is serving in this role is actually working at that site and not someone who's just coming in to help do some QI efforts. So they were able to make a lot more changes in a much more efficient or timely way by being on site. So that helped.
Okay. Well, Joyce, I see your question there. I think that I might put that offline at the end just because this parent-centeredness of weight in kilos is an important topic, but I think we might be able to end up talking about it for 40 minutes. So I think let's defer that to the end. And then I guess, Sujit, if you can comment on some of the funding aspects, I see specifically, and I know from speaking to you and Kate, that there is a position of Director of Outreach. This has come up on prior community of practice calls and discussions of actually formalizing not only in the community sites, but potentially in the tertiary and quaternary care sites. So I don't know, Sujit or Kate, if either of you want to comment on that, sort of long-term sustainability by creating, titles and positions like Director of Outreach, if you guys have thoughts on that.
Sujit, I'll let you take that one since you're in that role now. Are you on mute?
Oh, can you hear me now? Sorry.
Yep, now we can hear you.
Great, thanks for the intro, Mark, and I'll get through these slides and leave plenty of time for questions too. So just as a quick background, I'm lucky enough to work here with Kate, who's clearly a leader in this field and kind of set the ground for success here. My background is education, so I'm Associate Fellowship Director here, run the clerkship here, and do most of the evidence-based guidelines for pediatrics for our tertiary hospital. And on the heels of what Kate had started doing by reaching out to these sites physically, some of the executives said, really, should there be an organized program to continue diving into pediatric readiness and improved quality, and specifically into clinical care. From the executive point of view, the real question was, could a hospital that has a medium to large size pediatric volume, so by their definition between 15 to 20%, actually deliver some of the basics of pediatric care at the same level that we do at the children's hospital? And I think using the readiness format, we said, yes, this could be possible. So I'm going to just talk in a few slides about what's worked, what hasn't worked, what we've learned, and then please ask some questions. Kate, you can go to the next slide. I think you have the control. So and I have no disclosure. So as a background, Kate already described a little bit about what Austin is like. Obviously, Texas is a very big state. Our entire catchment area for our children's hospital is 46 counties, which, as was mentioned, is about the size of the state of Ohio. When we tried to sell the story about why this was important for community hospitals, we really first looked at how many pediatric visits were happening within the network. And what we saw was our total network saw about 150,000 outpatient pediatric visits. About 80,000 of those were at the children's hospital, which left almost 50%, really closer to 40%, all spread between the other community hospitals. And this is the first step in showing many of the executives at these community hospitals that you are a children's hospital. In fact, some of these had volumes up to 20 to 25% of their total volume. And I think many sites that saw as little as 300 visits per year just simply did not really believe that their impact was that great in pediatrics. And when we first presented this to the network, we said, we are two different children's systems. We are the one at the children's hospital, and then we are the culmination of all these other hospitals. And that was the first step in explaining why an organized approach to do outreach and education for all of these community hospitals was worthwhile. You can go on to the next slide. So the balance that we saw at every single one of these sites, and that continues, this project is going on now for 2 years, is shown in this slide. I don't think anything on this slide is different in Texas versus any other area. On one side, the incentive to improve pediatric care at this hospital was very clear. The community would complain, either online or in person or by word of mouth, that really they were tired of driving to the children's hospital to try to get the same level of care. We saw that other competing hospital systems were starting to advertise pediatric care, which was interesting, considering that all of the content knowledge, expertise, and subspecialty care was obviously within our system. And we had already seen from Kate's work that there were actual tangible benefits by just being organized. And I would just say that every single little thing that Kate did, those were not small successes. So getting an actual pediatric crash cart in a hospital is a big deal. Getting an infant scale that was only set to measure in kilos is a big deal. And it was the first step in just letting people know that they do, and remind them that they do pediatrics. However, there are obviously continued competing needs. If there's not any complaints that the executives here or the directors here, I think many of our sites, especially those that saw between 10 to 15,000 kids a year, said that they do pediatrics just fine. And I'll show a little bit about how we address that. There's of course competing initiatives. So trying to improve pediatric care while a community hospital is also trying to achieve level 2 trauma status or become a stroke center can be very hard. And if you don't show them that there's any actual need for improvement at their local site level, it's hard to kind of convince people that maybe things should be done differently. And then I think almost every single site, large or small, will say that there's of course a limited amount of resources. And we can talk a little bit in these next couple slides about how we address that issue, leveraging the Children's Hospital as an area to help with those gaps. Go to the next slide there. So this is kind of the 3 things that we asked to do at every single one of our community hospitals. So the first things first was we met in person, and what we did was we did not try to make the clinical case on why hospitals should improve pediatrics. We actually sat and heard from local bedside nurses on what their experiences was with pediatrics, how comfortable they were, and we used those stories to actually then dive into charts and then develop a clinical case for why pediatrics needed to be improved. We went directly to the executives. So we went to our C-suite councils and we showed them the data that I just showed you. I would say that 75% of them did not realize that as a whole, they represented a large pediatric volume. We talked about their opportunities in their market, and we proposed to them a monthly business review to actually look at their pediatric volumes and combine it with the clinical review so that there was actually an administrative side to how we looked at pediatrics. And then we committed to a parent hospital responsibility. So what Mark kind of alluded to was that there was a designated role for a physician outreach director that was developed. This was 15 hours a month. The nurse outreach director role became part of the current educator role at our children's hospital. Our CNO and CEO said that we will fill in the gap for any supplies that may exist at community hospitals. And we actually committed as a subtotal to commit between $20,000 to $30,000 per hospital for things like painting the walls, decorations, and things like that if they were needed. And I'll talk a little bit about that. So one of the things that we noticed is that once we started diving into clinical cases, step 1 was convincing people that they did pediatrics. Step 2 was actually figuring out how their processes work. And then step 3 was really motivation. And one of the things that we found that was a big motivator for many of these hospitals was comparing their performance on pediatrics to other hospitals. We don't probably have enough time to get into every single one of the clinical domains we improve, but what's shown here is a graph of time to albuterol that we did for every single one of these community hospitals. We went to the back of the EMR and developed a dashboard, and that red line represents their goal, but what you can't see here is that this community hospital that sees between 7,000 to 10,000 kids per year delivered steroids faster and albuterol faster and scored more kids on a standardized score than we did at our children's hospital. And we really applauded that work. We put it in front of our children's hospital, and we really showed them that there's actually opportunities to deliver care that's even better. And that peer pressure really made them feel confident then to move on to pain control, laceration care, and other things. And so we pitted hospitals against hospitals that were the same size. We basically put their data in front of each other. And what led was that they then started just wanting to compete with us. And that really worked well for albuterol and asthma care. And this is kind of the 4 buckets that we use to improve care at all of these sites. So once a month, what I do is I actually meet with every single one of these hospitals. I developed a slide deck that's no bigger than 5 slides, and we cover these 4 domains. We ask that somebody from the C-suite be on the call every single time. We use some of the pediatric champions that Kate had already developed, but we also ask for directors to be there and for bedside nurses to be there. And we cover these 4 domains once a month. We cover supplies because despite doing things like delivering pediatric crash carts, those things, if not maintained, will slowly deteriorate, supplies disappear. And we actually manually review a checklist based on the clinical domain that we're reviewing for the month. We make sure that any expired supplies that are at outside hospitals actually come back to our children's hospital, and we give them fresh supplies. So we have a process so no hospital actually has expired pediatric supplies. And then when we're talking about supplies, we actually talk about on-site training. We do monthly calls mainly focused on different clinical domains. So if we're doing a call about intranasal and lat care, we ask them, how comfortable are you with using the atomizer? How comfortable are you using? And that actually drives what education we made. So the next box is actually clinical training and education. So we focus on cross-training personnel. It may not work in your system, but we have many nurses that work at different sites based on where they live. All of our respiratory therapists are cross-trained to work at all of our hospitals. So we focus on cross-trained personnel. We do on-site training when possible. And then we develop education based on what these bedside nurses are telling us. By engaging with them at the beginning, we get real feedback on, do you read your emails? Do you look at those newsletters? Do you read this PDF? And of course, the answer is mostly no. And because of that, we actually developed a YouTube video training series, as well as an internet site, which each video is no more than 6 minutes. And that has probably been the greatest success. So for intranasals, we cover how do you do this? How many people do you need? We walk through it. And it's been such a great success that we're going to do the same thing for vital signs. So people have the information on vital signs, but we know from chart review that they're still not comfortable doing blood pressures on kids. They're not comfortable with the tips and tricks on how do you get a blood pressure on a 2-year-old. And so we're making a video on that. We use data. So that 15 hours a month, I would say half of it is spent manually reviewing charts. But we'll talk about how you can do that efficiently. We develop a monthly operational review, and we keep the data very, very simple. For every single clinical domain that we try to focus on, we only try to focus on 3 areas of improvement. And I'm going to show what that looks like for pain control and laceration care. And then the last thing we do is for every single meeting, we try to advocate for somebody at that local hospital. We online will call the people before the executive gets on the call and ask them what are their barriers. And we will ask those executives for more time and more hours. We will ask them to pay for 2 or 3 hours for one of their nurses to come to our sites. And it is very hard for those executives to say no once we're on a call reviewing what they're working on. We praise their wins and we aim for success. I always tell them we're not aiming for you to all of a sudden transform how you do everything, but you can make big steps to success with just a little bit of focus. And I'll just show that real quick before I finish my section. So you can go to the next slide. The next slide shows kind of how we do each of those different parts of improvement. So for supplies, we try to help with the easy part of the children's hospital. We provide free scales. We take their expired supplies. We actually help them organize a pediatric cart, which includes IV supplies. For training, we always try to go to them, and I mentioned kind of doing things in a multimodal way, like on YouTube and online. And then for access, although I can't put a pediatric neurologist in their hospital, I can do things like give them cards that give them backline office numbers that they never had. We centralize protocols, and we actually allow any single one of our hospitals to refer any family to our case management team here at our children's hospital as a way of navigating the very complicated system that is referrals. And so that's a big help. Right here is just a snapshot of what we do in our monthly review. So the picture on the left shows for the executives what they want to see. They want to see how many kids they're seeing per month. This, again, reminds them of why they're working on this. This hospital considers themselves to be a small hospital, but really they see between 15 and 25% pediatrics. And we remind them what type of diagnosis that they see. The slide on the right shows how we focus on clinical care from chart review in a very, very focused way. So you may not be able to see, but for laceration care and pain control, we focus on 3 simple things. We wanted 100% of kids to get let gel on their face. We wanted kids who are less than 5 who had a simple laceration to their face to not get injected with lidocaine. And we wanted kids who were less than 5, if it was appropriate, for them to get intranasal medications. And those are all digestible metrics for any bedside staff. And by filtering out only young kids, we only had to review about 15 to 20 charts per month for a site like this. And just by really diving into that, within 6 months, they hit 100% on almost all of their metrics. And so by filtering down to really the most important patient population, if we just did all pain control, I don't think we would have gotten anywhere. But by focusing on this, they really were able to adopt some best practices and get more confident to then do the next thing, which our next focus is vital signs. I'll just kind of close by saying momentum is hard. So the graph on the left represents all of the champions that Kate had spent all that time working on developing at all of those sites, meeting them in person. Out of that entire list of people, only 3 of them are around or in roles that they were in 2016. And so we had to really get commitment from the C-suite to say that by having this role, this is part of the promotion schedule for any nurse. And here we call it the Nursing Portfolio Project. I made a commitment that any nurse that made this their project for promotion, that I would help them with data and chart review and even build their application for promotion. And it was not that hard. I really was able to just cut and paste graphs and really kind of summarize work for them. And by doing that, we were able to re-recruit those champions. You can go on to the next slide. I think that's probably about all I got. And then, so these are kind of the pushing the right buttons that we try to do at each of these places. And I think this is kind of our graph. Our next step has been that because we run a fellowship program, we're lucky enough to train trained doctors that then go on to work in the community. And so what we've done is now use this template that you see here, and we have graduates that are now EM trained, so they have general EM board certification, as well as Peds ER trained, that are now working in these community hospitals. And as I say, the role is they're no longer to be a role for me anymore. It's for me to be able to train the doctors that are working at those sites to be pediatric champions, and they use this template for every single time they're rolling out a new set of improvements. I'll stop there. Maybe we got a little bit over, but plenty to talk about, room for questions too.
So
there's Sujit.
Yeah, so there's Sujit. I saw a couple questions listed. I think one of the themes that came up was sort of, is many of this, are many of these interventions feasible because this is within a single health system? So, for example, sharing of equipment, or even getting motivation and buy-in, and lots of fantastic work. Not fantastic work. Nice pick comments.
Yeah, I think being in the same healthcare system has so much leverage, and honestly, because we're in the same healthcare system, you can put all of the executives in one room, and that peer pressure that we talked about at the bedside level actually applied even more when we showed the 2 hospitals or 3 hospitals that were adopting our best practices and the others that weren't. It really put a lot of pressure on them as they were all part of the same system. So.
Thank you, and I think we'll hold the rest of the questions till the end. So Marianne will be up next, and really fantastic work, and hopefully this will prompt some ongoing discussions. So we'll hear next from Marianne Guasche-Hill, and hear after that from Nancy. So Marianne, I believe, let me just see if I can give you remote control. So Marianne, you should have remote control of the screen now, or not. Why don't you, let's see. Nope, it's not letting me do that. So I'll just advance slides. So let me know when you want next slide.
Did you want me to share the desktop? Because then I could.
Yeah, that's perfect. If you want to do that, that's great. I tried remote control.
Hold on.
There was some security with that.
Give me a second.
Okay. So Marianne, for those of you that don't know her, is an absolute legend and mentor to many of us. She's the medical director of LA EMS Agency, a professor of emergency medicine and pediatrics at David Geffen School of Medicine, and really has many disciples, I guess you could call us now, that are trying to take forward some of the great work that she's and Nancy and others have done in LA. So exciting to hear sort of where they are, and then a place that I think we can all try to aim to be in another. We got a couple decades though till we in time to catch up.
Thank you, Mark. It looks like it is not allowing me. It said share desktop, but now it's not doing it. So let me just see if I can.
It says you're controlling. Try to click.
Oh,
yeah.
There. Okay. There we go. Okay. Sorry. How's that? Can you guys?
Try to advance the slide and see what happens.
Okay. Nope.
All right, I'm going to abort control and just drive for you. So.
Okay. That's weird. It looks like it's, wait. Oh, it said the other participant is sharing. So.
Okay, so let's try that. Let's try that again. You may be able to.
Okay, now let me try it. Share. Oh, it's telling me I can't do it.
Okay, so I'll drive for you. Go ahead.
Okay. It was very difficult to decide what to say on this webinar. There's so many things to talk about. So I thought I would just get an overview of what we've been working on for many, many years, and a little bit of context on why I believe that what our successes are and what our challenges are. So let's move to the next slide. In the early years, it was really clear that specific needs of children need to be identified. And I think doing a needs assessment in the community, and I really like what Kate and Sujit have done in Texas, I think it's really helpful to understand what the needs are for kids in the area. It was clear that we needed some kind of regionalization plan for rapid transport of critically ill and injured children. And at the time, there really were not, in the early 80s, there were no equipment guidelines, there was no specific education. We often had pediatric patients arrive at the back door of a hospital and turned away. So with that said, my mentor, who was Jim Seidel at the time, who received one of the first, who did receive one of the first 4 EMSC grants, was very interested in working with local AAP chapter to develop specific guidelines for facility recognition that could be implemented in a large EMS system like Los Angeles. Next slide. So this was in 1985. These efforts were started 1984 and 5. Actually, in 1984, the initial federal legislation was passed. In 85, we began the project in California, for which I served as a fellow. And one of the things that we needed to look at was what kind of tiers, and many people wanted multiple tiers, but that became problematic when you try to implement within EMS systems. So as an example, with 4 tiers, how do you distinguish triage for patients for more than one tier? And it became problematic, so it was decided that there be 2 tiers. There are pediatric critical care centers and EDAPs. And then in 1990, there were continued state implementation grants. That grant was with Ron Diekman. And we established standards for emergency departments at that time. And there was some pushback at a federal level, at a national level between AAP and ASAP on how we could work together on guidelines. And AAP felt it was in their wheelhouse, and ASAP felt it was in theirs. So thus began my collaboration with AAP and ASAP to help develop guidelines for care of children on a national level. And Jim Seidel and myself did this in California. Next slide. So the urban EMSC system looks something like this. You can see with the yellow triangles that patients within that catchment area would be transported to an EDAP. So any children for which 911 was called would be transported to an EDAP. They could then be secondarily transported either by air or ground to a pediatric critical care center, which is a regionalized center that has a pediatric ICU and subspecialists. Some of those patients you can see in the pink triangles would be transported directly to a pediatric critical care center based on certain criteria. And we do have those criteria even today. So as an example, children with severe respiratory distress, dysrhythmias, children with status epilepticus, now BRU or parent life-threatening events before. Also focal neurologic signs without trauma. So we wanted to get those patients now. We added that as well as post-ROSC patients because all of those patients are going to require pediatric critical care. So those are just some of the guidelines. And so just to be clear for those on the call, in our system, the way it works is that if the patient is 14 years of age or younger and EMS is called, they can only be transported to either an EDAP or a PCCC, which are now considered pediatric medical centers or PMCs, okay? Or they could go to a pediatric trauma center, but they can't go to a community hospital unless that community hospital has been verified. Okay, next slide. And I'll let Nancy talk more about the nursing coordinator for pediatric emergency care. In Los Angeles, these are called Pediatric Liaison nurses, and this nurse advocacy led really to the formation of this organization, which Nancy helped start. So I'm going to defer much of this to her, but one of the things we found is just by assigning the role of physician and nurse coordinator, it made a difference in terms of quality improvement, access to policies, procedures, and equipment. Next slide. There are many products that come from EDAPs, like the vital sign cards. This is just what do EDAPs have to offer, just a little bit about our emergency care system. Next. The other thing that we did is we allowed hospitals to basically advertise that they had met the standard, and so we created an actual poster, and so all of our specialty centers have posters. They can't advertise unless they've been designated by us, but once they're designated, they can advertise, and we provide that poster. We provide that signage for them, which I think a lot of the hospitals like. So I'll throw that out there as potentially something others can do. So as I said, facilities that meet the guidelines for an EDAP or PMC or PTC, once they meet those guidelines, we actually go on site and do a verification that they've met the standards. And I'll just show you an example of our standards. All of our standards are available online, by the way, for anybody who wants to download them. And once the facility is designated, then the 911 patients will be transported to them. As I mentioned, paramedics are trained for those triage to those sites, so I think that's important. And then we verify these sites every 3 years. We're trying to expand our verification process. We've always done on-site review of policies, procedures, ongoing education, certifications, and chart review tools. We're asking each site to provide, and it was interesting, Sujit, that you provide all their volume stats and everything. We're asking each of the sites now to not only go online and do the National PEDS Ready and report their PEDS Ready score and trends over time with gaps and what they've done for the gaps, but also just some basic stats about their pediatric patients. One of the things we found out with the PEDS Ready score is that the thing that stopped people from doing the online assessment was their pediatric volume. People didn't know how many children they saw. So I thought that was fascinating. So we decided to incorporate that within our on-site audits. And so now everybody's doing a report. And then there's ongoing education every year regionally, and the pediatric liaison nurses have really championed that. Okay, next slide. And we had started in the state a EMS per Children committee, which this was long before it was required. We then passed legislation in 1996, basically codifying an emergency medical services for children program with a statewide EMS for Children tag. In addition, so that created a really a national presence. Next. Sorry, I must have. This is our EMSC Act of 1996, just again codifying the program, and our technical advisory committee for the state of California. Next. Fast forward to the California Pediatric Readiness Project. This was Kate's fellowship project, believe it or not, but we had a tipping point with the national program being interested in what we were doing. And so this is the California gap analysis. So each of the states got their gap analysis. And so we felt this was so important that the portal remained open, and to date there have been any of a number of projects within California in local EMS agencies to improve their readiness. As an example, Alameda County did one, we did one through Kaiser, we just finished one with the LA Pediatric Readiness Project as well. I don't have time to talk about that project today, but maybe in the future we can talk about it. Next. In addition, as I said, this was the pilot for NPRP, and we were able to get 90% of our hospitals within California to participate. And what we did find in this, and Kate, if you want to chime in later on this, that 51 of the hospitals within California had a formal on-site verification verification process like LA, and 31 participated in regular assessments. Next slide. And what we found out, which I think was really important, that I just wanted to impart with this group, and I certainly have known this to be true in LA, is that the on-site verification is very important in terms of hospitals improving their readiness. If you just get assessed, meaning we ask you, are you doing this? And they say yes, you can see that the median weighted pediatric readiness score is not elevated, but once you are increased, but once you go on site and do verification, regardless of the size of the hospital, it makes a huge difference. And in LA, what we found, since we do on-site verification, when we looked at our EDAPs versus our non-EDAPs, you can see a dramatic difference in terms of readiness. And now, and also in the paper that was published in Pediatrics recently from University of Pittsburgh, as well as with our group, the NPRP investigators, we showed a decrease in mortality, and one of those states was California. So it's interesting to me. Next. Currently today, we have 38 EDAPs. You can see we have 10 PMCs. These are our pediatric critical care centers, and 7 pediatric trauma centers. Next. They're widely distributed throughout. We have an ongoing engagement by all the stakeholders in our system. We have created a pediatric advisory committee with representatives, and this started just before I became a medical director. And we've established standards, so we have standards for PMCs and our EDAPs, as well as we have some guidance about our Pediatric Advisory Committee. Next. The other thing that we've learned is the Pediatric Liaison Group, who've organized themselves, are basically critical stakeholders to keep all this going. They have incredible amount of resources, and they continue to be strong advocates for the system. The other thing we learned, as I mentioned, is on-site visits by EMS verifies compliance. It helps identify gaps in best practices, which are shared. Next. In addition, we realized we needed separate pediatric protocols. So all of our provider impressions now, we have separate pediatric protocols online. And we're working to get more point-of-care access to all of these pediatric protocols. Next. I'm getting there, almost done. The other thing that we learned is bringing resources to the pre-hospital provider makes their job easier, more accurate, creates less stress. And so we also standardized our formulary, created a medical control guideline, and have pre-calculated all drugs. And you can see this is the 12 kilo, so they never have to calculate again. In addition, on the right, I don't know if you can see it, but we have an app, and we are just about ready to release that app, and that app will be free to anyone in the United States who wants to use it, but you have to have a similar formulary as us. But we've already shown a decrease in error rate and an increase in satisfaction. Next. The next thing that we tried to do is create greater engagement through an LA Peds Ready toolkit, and I want to thank Mo Sidinajad for his work on our toolkit. And again, we want to try to promote other education through our toolkit. We have all the clinical policies. We reviewed them, and we try to update them from various children's hospitals all around the United States. Next. We've worked with Mark and his team to develop mock codes, and so we've investigators from Harvard UCLA, Patricia Pedlipsky in particular. We provided mock codes to 24 of our non-EDAP hospitals. This was so well received. My plan for the future is to have, as part of an audit for our hospitals, to engage in a mock code. We also develop pediatric search templates, and so these are available for our hospitals. All they have to do is kind of fill in the blanks, and that has helped improve their pediatric disaster capabilities. Next. And then years finally of advocacy in this arena has led to the implementation, the passage of regulations for EMS for children. So EMS for children within California will spread to all of our 300 hospitals. So we're very excited that passed in July of 2019. Next slide. So what are our next steps? Is to implement California regulations for children throughout the state, coordinate resources locally, regionally, and nationally through toolkits and other online resources. We have continued engagement, including our pediatric champions from regional centers to improve care in the entire system, and hopefully some ongoing research to establish best practice. And with that, I went as quickly as I could to get Nancy to talk about the Peds Liaison nurses.
Thank you so much, Marianne. So Nancy, I'll help to drive. So Nancy is a giant of nursing and nurse practitioner out there with Marianne and others in LA. And I had the pleasure of going to speak at this Pediatric Liaison Nurse Conference. And it was sort of the pipe dream of what I hope can occur in the country, to have nurses from every hospital just like, ready to devour, like they're at an all-you-can-eat buffet, as much pediatric content and knowledge as they can get in that day, and so engaged, so passionate. So thank you, Nancy, for coming out of quote-unquote retirement, which we weren't letting you do, and sharing some of your stories. So I will advance the slides for you.
Okay, great. Okay, can you hear me?
Yeah.
Okay, great. Well, Mark, I like your T-shirt.
Thanks.
You wore it just for us, didn't you?
Yeah.
There you go. Okay, I'll go quickly because I think we're running out of time. So the Peds Liaison Nurses really was a pipe dream of Dr. Seidel's, and it all started with the development of the EDAP system. The group first started meeting in March 1986, and up there are two pictures of the true leaders, the matriarchs of Peds Liaison. It's Jan Fredrickson on the left and Fran Todd on the right. I also need to say Debbie Henderson was very instrumental in getting this group going while she was working with Jim. And the group meets every month, and we have continued to meet the fourth Tuesday of the month for all of these years. And it's a very great, receptive group, and we are all dedicated to improving the care of kids in LA County.
Nancy, I'm gonna interject real quick. Take your time. You don't need to rush. If we go over, this is being recorded, and if anyone needs to step off, I will send out the link, and I'd love to just make sure we give you the time you deserve. So please don't feel that you need to end right on the hour, and I'd like to cover everything, and we'll send out the video after. Thank you.
Okay. All right, great. So we started out with 77 EDAPs initially, and now we're down to 38. I thought it was 39. And each facility does have a PEDS liaison nurse. Initially, it was a very limited position where you just had to have some experience in pediatrics, 2 years in any type of pediatric setting. Now it's very specific to ER nurses, and you had to have a 2-day course. We've expanded that over the years, and you'll see as we go on. But the initial job was really just to get in there and, promote the high standard of care for kids, so bring everybody up to date, coordinate some type of education for your ED staff or get them to go to education, and then start what was a quality assurance program back then. And you really only had to look at 10 charts a month. So it was a really simple type of job, but, and you were given about 4 hours a month to do the job. Some people yes, some people no. And that was a big issue, and it is still a big issue to this day, but it is getting better with Marianne at the helm at EMS. Next slide, sorry. So initially we met at 3 facilities. You know how big Los Angeles is. We just met at 3 central facilities, but now with the traffic, we meet all over Los Angeles County, and people drive 100+ miles to come to the meeting. So it's a very dedicated group. And initially it was really very grassroots. Like, what are you doing? What can we help you with? How's your job going? But we've become very sophisticated over the years, and we have a strict agenda, a time frame, and we get everything done. Whereas before it was kind of like chit-chatty. There have been guest speakers over the years on a variety of topics. In the beginning, much more frequently. Now we have more conferences, so we kind of have bigger groups of people together. It used to just be the PEDS liaison nurses. We developed our own bylaws and started our own board in 1986. I actually didn't come to this group till 1988 when I moved here from New York, where I was at Jacobi with Emory. And so I got involved in the fall of 1988, and that's kind of where my beginnings came from. But I worked with Jan and Fran and Debbie Henderson on trying to get this group together. So it's really come a long way. The first conference was in 1987, and we have continued to do that since. This is the 32nd 2-day conference that we've held, 32nd annual conference, but we've had 34 years of conferences overall. And we are estimating, last night talking to the other PEDS liaison nurses, we're thinking that we've educated somewhere between 8,000 and 10,000 nurses in Southern California on PEDS emergency care. So we feel pretty proud about that. And that really is our big mission, educating nurses how to take care of kids. Interestingly, in the late 80s into the early 90s, we were approached by the Emergency Nurses Association, and they were interested in our group and how we educated everyone. And they're like, well, we'd like to have a course, so would you guys help us? And so Jan, Fran, and I, and Debbie Henderson were all involved in the development of the Emergency Nursing Pediatric course. And it actually really, I believe, stemmed from Debbie Henderson's and Dina Brownstein's book, Pediatric Emergency Nursing Manual, which was all case-based scenarios to teach nurses how to take care of kids. And so EMPC kind of stemmed from that. And so, it's just kind of grown since there. Now we're up to the 5th edition of it. We also were able to sit on some of the EMS committees, and that has grown over the years. We sit on much more, so many more committees at EMS and throughout the state. But, the real goal, and this was Dr. Seidel's dream, that we would have this nationwide network of pediatric liaison nurses, which now with Readiness, this may actually come to fruition. It would be great if, like, emergency nursing had a SIG for pediatric readiness, but it is growing. Next slide. So as we were talking about, the job has just kind of grown over the years. And so what was like 4 hours a month has kind of grown in some institutions to a full-time job to really be able to dedicate the time and the energy that you need to really make this program successful. And I will tell you that overall, I can't say this enough, you really need a dedicated person at each facility to really get things moving and growing. And we have found that each and every place that we've been to. And the responsibilities have grown over the years. So not only are you responsible for policies and procedures and equipment, it's education, it's QI, it's interacting with anyone and everyone in your facility who ever puts their hands on a child, dealing with the EMS agency, you know, going to meetings. So not only the Peds Liaison meeting, but also the PDAC meeting. And then of course, the big stress is your every 3-year survey, where everything you've done for those 3 years is looked at by EMS. So it's an on-site survey, as Marianne was talking about. It's extremely stressful. When people hear about this and they don't really get a lot of time, they like wig out and they don't really want to participate. But I think now that we're moving forward and there will be a job associated with this, I think it's going to make the system even better. And I think we'll actually, with the QI, be able to get much better outcome data and improve readiness just overall. Next slide. So there's 38 EDAPs, not 39, and we have about 45 PDLNs. Some facilities have 2, and just because they help share the work and it gets things done a little bit more efficiently. When we have done surveys of the PDLN role over the years, which is why this is an important component of the new EDAP standards, is that some people got absolutely no time to do this job. Some people got 40 hours a week. So because there was no contract, there was no specific position associated with the EDAP system. Even though we were one of the earlier systems, it really just didn't have that same feel as the other base hospital or trauma had. So, but now that's changing, and I think, again, this is going to be great for children everywhere. Marianne has really kind of helped us with that. Okay, next slide. So this has a lot of work. I just want to tell you that we do a lot of different things. But again, our main focus is on education and outreach to the facilities that are nearby us. Or now that we've done this readiness project, the LA County Pediatric Readiness Project, we've all maintained our relationship with the hospitals, the non-EDAPs that we worked with. So we're kind of still their champions, even though the project is over. But we have, we put on a conference every year. It's very self-supporting. So registrations help us pay for everything. And Mark, you were a speaker. You could, it is a great conference. People come from all over and the nurses really enjoy it. It's great education. We have great speakers. It's in a beautiful environment. And they really enjoy that day away from the hospital, those 2 days away from the hospital. So it is possible. It just takes a little bit of legwork to get it done. We co-sponsor conferences with other hospitals and California emergency nurses. We have a website. It's not the most up to date, but we do try. We at least put all our education on there. It's pdln.net. We sell clothing to make money to support our group and other items. We send our members to educational conferences throughout the country, ENA, ACEP, AAP. They come to the California EMSC Educational Forum up in Sacramento every year. We also help to support rural pre-hospital providers so that they have a chance to get some education because it's not as readily available as it is here in Los Angeles County. As Marianne was saying, we do sit on some committees. The PDAC committee was probably the greatest thing to happen to the Peds Liaison nurses because we really didn't have much of a voice at EMS. And now we feel that we really are a part of the system. So Marianne was working on it from her end. We were working on it from our end. And in 2011, it finally came to fruition. And we get a lot of great things done there. Again, we sit on those same committees, Base Hospital Education Technology, California ENA. There's 2 of us that sit on the Pediatric Committee for the State of California Emergency Nurses. And we also sit on the State of California EMSC Technical Advisory Committee. And so we really are able to kind of bring everything together in terms of pediatrics on the nursing side. In terms of research, we've been involved. First, we were involved in Kate's Pediatric Readiness Project, and that was phenomenal. And that really got the group really interested, and we got a lot of buy-in from people who are now like diehard Peds Liaison nurses and will do whatever Marianne needs or EMS needs to get done. And then the Los Angeles County Pediatric Readiness Project. As Marianne had already alluded to, we did 24 mock codes at the different community hospitals, and we gave them all types of resources. They're now our buddies. We have this whole program with them, and I think it's just will continue to grow. We've also done other studies over the year with EMS on ALTs and Peds Assessment Triangle. We help the fellows with their studies that they're doing if they need information from other facilities. And we've done our own little studies on sweeties and pain management over the years. Next slide. This is just a couple of pictures, like Marianne was showing too, of the mock codes that we did. And the nurses were really involved. I mean, Mark, you know that from doing your own, and Dr. Pedlipsky, who really kind of spearheaded it all for us. And that's just a picture of our little team from Harbor. We went to all of them, and we had a great experience. And we would love to do it again. Love to do it. Peds liaison nurses talk about it all the time. We want to do this. We want to do this. Really enjoyed that community outreach and getting into the small hospitals, because we all get patients from these facilities. So if we can help them up front, it's even better for us on the other end. Next slide. So as Marianne was talking about, these are some of our recent activities. We work really closely with EMS. We're trying to get all the EDAPs to get their disaster surge template together. It's there, they just need to use it. So every meeting we talk about it. We're trying to update our policies to meet the new EDAP standards that we've been working at the PEDS Advisory Committee. We've worked with EMS on the field protocols and the provider impression care maps. And this year, EMS has now a new orientation class for the new PEDS liaison nurse. So that is brand new. We've never had that before, and the whole time the system has been in existence. So this is great. We actually, feel like we have a seat there. We continue the pediatric readiness in terms of research. We don't do a lot of research, so to speak, but we're very happy to participate in any project anybody has regarding kids in LA. And again, we are still working with our non-EDAPs. The PEDS liaison nurses just completed collecting data for the interfacility transport within EMS. So that will be coming about. And we, like Kate was talking about, the importance of QI and getting people to know how to do it. We work on this all the time at PEDS Liaison, so that the new people really understand the importance of QI and know how it, will lend to the system. And that's really it. So we can have better outcomes, we can be better prepared, have better readiness. So that's kind of where we're going with our quality improvement. And of course, we constantly are mentoring our new PEDS liaison nurses to get them to understand the importance of it. Next slide. This is our website. So feel free to jump on it at any point. And next slide. This is just these are the 4 conferences that we had this year that are highlighted in black. We had 4 large pediatric emergency care, so to speak, EDAP conferences throughout Los Angeles County. It covered the whole county. So, and between all of them, there were probably 1,000 people who got PEDS emergency nursing education. This just shows you, and then up above is the Pediatric Readiness Project Conference that we had in 2017. And these are just our clothing and our pins and things that we sell in our monogram and things like that, kind of like let everybody know about EDAP. And I think that's it. Next slide. And these are the 3 entire publications that are out on PEDS liaison nurses. So we have 3 total, and that's it. Quick, to the point.
Thank you so much, Nancy. I really appreciate it and appreciate people's time staying over. So I understand if people do need to go. Nancy, Marianne, Kate, and Sujit, if you can stay on, I'd like to open up the floor to questions. So the mics are open. If anyone has any questions now, go ahead and ask them.
I have a question. This is Lindsay Query. I'm at Children's Mercy. And I'm just curious, I mean, first of all, thank you for presenting your work in both locations. It's just so inspiring. My question I'll frame, we were recently approached by, the Children's Mercy in Kansas City is not part of an established network of hospitals like Kate's hospital is in Austin. But we were recently approached by a local hospital looking to become child-friendly or PEDS ready and wanting to do some verification. Of course, Kansas doesn't have facility verification yet. So I'm just wondering, all of these things I would love to do today, but where do you start in this? Because aside from the needs assessment, like when it comes to identifying stakeholders and leveraging the C-suite and all that for institutions in different networks who want to work together but are technically in competition.
Can I offer just something? This is Marianne. I don't know if you guys can hear me.
Yes.
Okay. The Evelyn Lyons and I were asked to go to Delaware, and we actually did that at Nemours Children's Hospital. So we developed some, basically communication tools with them for us to be able to come, and we utilized their guidance for their standards, and we created a checklist. And so that worked out really well. But one thing that you can do is you could just utilize the checklist from the last assessment. There'll be a new checklist for the latest assessment that was just published in online in 2018 and then on paper in 2019. So there could be a checklist, and you could potentially partner with those hospitals to go and utilizing that checklist, see how PEDS ready they are. So that's an opportunity. The other thing is the portal is still open. They could go online and check their own readiness, and then you meet with them to go over their gaps and see if there's any way that you can help them achieve their gaps. And then my last, oh, sorry, go ahead.
Oh, Marianne, I was just going to say that based on some prior calls and today's discussion, I think one of the key things that I certainly have heard from you and Nancy and others is having that local champion, that no matter how much improvement you do, that having an individual that they've identified. And then I didn't realize, Nancy, some people are getting 40 hours per week, but if that local champion is at least getting some time and a title, it seems, Lindsay, that goes a long way. So as opposed to this external consultant, potentially more of a internal collaborator that you're supporting. Sorry, Marianne, I didn't mean to interrupt, but I feel like I keep hearing that theme from many of you. The successful programs is it's all about having that individual that owns this in the community hospital.
I agree, Mark. I was just going to say that you have to have that, but sometimes it is nice to have these outside people to come in and help validate it. So that would be my only thought there.
Thank you for that. I just want to ask one more follow-up to that. So I'm just wondering, it's not lost on me the commitment that this takes, and so my division chief had asked if there was a tool, like a Delphi tool, that was already out there that sort of helps assess the level of readiness for the community hospital. Like, not necessarily in terms of like the pediatric readiness tool in terms of their systems level readiness, but more like their cultural attitudes and like whether they're ready to make the commitment. Because I worry that I will scare them off if I'm like, to make it work, we need this sort of upfront investment from you, and this is what we'll provide you. And I just don't know if anyone knows that exists.
Hey, Lindsay, this is Kate. I was actually going to jump in after Marianne around it, because I think what you're talking about is establishing trust with some of these hospitals and sites. And the fact that they're actually reaching out to you all and just showing an interest and asking for support is a huge step. And I think in order to establish that trust, giving them ideas and tools, you're right that if they're not part of your network, you can't really go in and do, patient level quality improvement work where you're looking at their performance metrics. But what you can do is potentially look at transfers that come to your institution. And I think some of the stuff that Sujit shared earlier, in addition to the work that Marianne and Nancy shared about how to develop those relationships and just some ideas for bringing on C-suite and partnerships. And I do think it does take time, and that you can't build those relationships overnight. But the fact that this is a community site that's likely transferring patients to you, that relationship becomes really important. And so, starting somewhere, helping to bring in even C-suite into a meeting where you can be present, or others from your institution can be present and willing to provide that support, can go a long way. But there isn't a cultural survey that I'm aware of. Marianne may know of one, but I think that's a great idea for a project.
Thanks.
Yeah, I'm not aware of one.
Yeah.
So I think it's good.
Yeah, Lindsay, I know in the management literature, there's change readiness type of surveys and things that I've learned about, but certainly nothing that I'm familiar with from a PEDS readiness standpoint. But I think it's a nice idea because it sort of says, yes, you want us to come in, but are you really ready to embark on this journey? I like that idea. Yeah.
Yeah. Okay. Thanks, everyone.
All right, well, we're about 20 minutes over, so I want to again thank our speakers with some virtual applause and really inspiring, but I do want to remind all of those attendees who have not been doing this for, a decade like Kate and Sujit, or 4 decades like like Marianne and Nancy, that these are not overnight successes. These take time, hard work, but I think the really exciting piece is through this community of practice and the relationships across the country, we can all learn from each other, and so inspired. I'm really excited to continue our dialogues and discussions, but just want to again thank the speakers for the hard work and time they put into the talks, and hopefully we'll get this up on the website soon and you can share that, and if there's any questions, please feel free to email me and I'll filter them along to the speakers. Thank you, everyone.
Thank you.
Have a great day. Bye-bye.
Bye.
Thanks for hosting, Mark.
Thank you.
Thank you.
Thanks, everyone.